I'm excited to welcome Dr. Schmidt to give our talk today, our Grand Rounds talk today. Dr. Schmidt is the director of the Oregon Psychiatric Access Line, and she's an assistant professor in the Child and Adolescent Psychiatry Division at OHSU. Dr. Schmidt completed her training in 2005 and has since practiced in a wide variety of treatment settings, including the outpatient world, inpatient, residential, group home, and day treatment. She has a special interest in working with children and adolescents with developmental disabilities and co-occurring mental health problems. Dr. Schmidt serves as the consultant psychiatrist to Samaritan Ministries in Ukraine. She's an international nonprofit organization committed to serving those who are less fortunate. Since 2016, she's led teams of mental health professionals to Ukraine to conduct training seminars for health professionals across the country. These trainings moved to a virtual format in 2020 and continue despite the ongoing war. In her spare time, she enjoys baking, running, bicycling, and gardening. Welcome, Dr. Schmidt.
Thank you. You can see my screen. I just want to confirm.
Yes, we can see your screen.
Okay, great. Okay.
Yep.
Well, thank you for having me. Today, I'm going to be talking about the Oregon Psychiatric Access Line about kids. I have no disclosures, nor do the planners of this educational activity. And these are the learning objectives. And in the interest of time, I'm going to jump right in. Okay, first, let's talk a little bit about mental health in Oregon. So Mental Health America is a national community-based nonprofit organization that's dedicated to addressing mental health needs and improving mental health or promoting mental health. They collect data from all 50 states, including the District of Columbia, and then they rank each state based on the combined scores of 15 measures that they use, and it comes up with an overall ranking. And the 15 measures look at both adult and youth prevalence rates for mental illness, as well as substance use, as well as access to care measures. And then every year, they release an annual report called the State of Mental Health in America. And in 2023, these are the Oregon results. So an overall ranking of 39 to 51 indicates a higher prevalence of mental illness and lower rates of access to care. And in Oregon, our youth ranking is 51, solidly at the bottom. And then our overall ranking is slightly above at 50. And then rates of, or prevalence rates, we ranked at 51. Our adult measure is slightly better. Interestingly, access to care is above or slightly below the mid-range, which is a little bit surprising. But suffice it to say, our mental health in Oregon is not too good. So what the report found is that 64% of Oregon youth with major depression do not receive any treatment at all, or any mental health treatment. And of these, 13% of those who are severely depressed, so meet criteria for severe major depression, only 13% of those receive some consistent treatment. And consistent treatment is defined as between 7 and 25 or more mental health visits in a year. And then in Oregon, of those youth who are covered, whoops, I'm trying to get rid of my, in Oregon, 13% of those youth who are covered by private insurance, their insurance does not have mental health coverage. Interestingly, I find this really interesting and sort of hard to believe, but the Oregon mental health workforce ranks number 3 in terms of availability, according to the State of Mental Health in America report. Now, what this report is based on is the number of licensed mental health professionals in the state of Oregon. And when I did a deeper dive, what I found is that we may have a fairly large number compared to other states of folks registered as mental health professionals, and that includes psychologists, psychiatrists, social workers, drug and alcohol counselors, licensed marriage and family therapists, and so forth. But the number of those that are actually engaged in full-time clinical work is far below what's registered. So it's something like 70%. So even though we have the workforce, not everybody's practicing full-time. And then the most recent data available is the 2021 data around youth suicide in Oregon. We are number 22 in the country. Now, we want to be 51. So we have the 22nd highest rate according to 2021 data. And I think our 2022 data is probably going to be pretty close as well. So it's not great. So looking at, this is the number of child psychiatrists in the state of, or in the United States. And the orange indicates a severe shortage. So this means 1 to 17 child psychiatrists per 100,000 kids. There are two, well, there's one state and District of Columbia, you can't see it on the map, but Vermont is green and the District of Columbia is green, which means that they have 47 or more child psychiatrists per 100,000 kids. So they have roughly adequate coverage. So the majority of states, there is a severe shortage. And then looking a little more closely at Oregon, you can see that we have 47, and you'll have to forgive me because I'm trying to move around my screen a little bit. We have about 147 child psychiatrists in the state of Oregon. Now, not all of these are practicing full-time, not all are involved in clinical work. That comes out to about 17 child psychiatrists per 100,000 kids, and the average age is 53, which is slightly less from last year where it was 54. And then this is how, okay, I'm sorry, I'm having a little trouble. Okay, this is how we compare to other states. So again, severe shortage. And then when we take a closer look at Oregon counties, you can see that there's only 2 counties in the state of Oregon where there's a mostly sufficient supply. That's Multnomah County and, interestingly, Benton County. You may ask why. Well, Multnomah County and Corvallis, or Benton County, are the 2 counties that have a child and adolescent psychiatry fellowship training program. And so they require a higher number of child psychiatrists to support the training fellowship. Also, in Benton County is Children's Farm Home, which is a residential treatment facility staffed by child psychiatrists, among others. So they also add to that mostly sufficient supply. The 2 counties where there's a high shortage as compared to severe shortage is Tillamook County and Deschutes County. The majority of our counties, 19 out of 36 or 53%, do not have a child psychiatrist in that county, and the remainder of the state has a severe shortage. Probably no surprise to all of you who have tried to access psychiatry for your patients. So enough about the dismal state of youth mental health in Oregon. Let's talk about something a little more positive and optimistic. So I'm going to talk about OPAL K today, and the seeds of OPAL K were first planted in 2006 when a collaboration between Oregon Pediatric Society and the Oregon Council of Child and Adolescent Psychiatry began. And at that time, both groups recognized the need for better mental health access in the medical home. And eventually a task force was formed incorporating a wide variety of stakeholders, including family groups, payers, state mental health leaders, educators, and a full array of medical providers. And the group, this task force, investigated programs around the country that were doing something to address this lack of access. And they came across 2 programs that were in existence at the time, and they're still in existence, but there's more of them. The first one was Massachusetts Child Psychiatry Access Program, or MCPAP for short, and Washington State Pediatric Access Line, or PALS for short. And both of these programs were state funded, and they found that it improved the primary care provider's ability to provide psychiatric care in the medical home through the use of child psychiatry consultation via telephone. And so following consultation with MCPAP and the PALS program, the OPAL K model was developed. In 2013, the legislature approved pilot funding for OPAL K, and OPAL K opened its doors in June of 2014. So OPAL K, the program is delivered by OHSU with significant ongoing collaboration with the Oregon Pediatric Society and the Oregon Council of Child and Adolescent Psychiatry, and with oversight by the Addictions and Mental Health Division of the Oregon Health Authority. So what is OPAL? Well, we are a psychiatric telephone consultation line for all prescribing clinicians in Oregon. Now, that includes pharmacists as well. It's akin to a curbside consultation, if you will. We do not have access to medical records, so when callers call us, all the information that we have is what they are providing verbally. We are state funded, and now we're a line item in the state budget. Initially, we started in 2014, again, as OPAL K, and then in 2018, we added OPAL A, or Oregon Psychiatric Access Line, about adults. And then in July of 2023, we began offering consultations with developmental behavioral pediatricians. So we call that OPAL K DBP. So why OPAL? Well, I'm sure many of you, if not all of you, are quite aware that primary care and other health clinicians provide an increasing amount of mental health care for their patients. And there's a national shortage, as you saw, of child and adolescent psychiatrists. So PCPs are often responsible for screening, for evaluating, and for treating mental health disorders. We know, this is a little bit old data, I suspect it's now more than 1/3, but we know from studies that at least 1/3 of all primary care visits involve mental health concerns. A cross-sectional study that was published in 2021 found that primary care providers provide most of the treatment for depression, anxiety, and really any mental illness. The same study found that almost 1/3 of the care for serious mental illness and 1/4 of the prescriptions written for serious mental illness occurred in primary care settings. The same study found that of the 50 million prescriptions written for depression and anxiety between the years 2006 and 2018 were written by primary care providers. 40% of those prescriptions in comparison were written by psychiatrists, and the remaining 10% were written by subspecialists. So primary care is doing a lot of, providing a lot of mental health care. We have a number of goals. Our initial goal was to reduce the number of children and now adults who don't receive timely mental health treatment. We also wanted to eliminate or bridge those long delays in accessing care. We also wanted to ensure that the mental health care that was being delivered was the appropriate level of intervention, that folks weren't over-prescribing or under-prescribing. And then we also, our aim is to promote utilization of a biopsychosocial framework so that providers are not just focusing on the biological aspect of a patient, but really looking at the whole patient themselves, their lives, social contributors and psychological contributors. Again, we want to support the appropriate prescribing of psychotropic medications, but we also that's not all that we do. We want to support the use of evidence-based treatments, including non-pharmacologic treatments. We also want to create opportunities for consultation, for mentoring, and education. And really importantly, OPAL wants to provide a service that is blind to all insurance, and it's statewide so that we can provide care to all Oregonians. So who can call? Any medical professional who is licensed in the state of Oregon. So how it works, our phone lines are open 9 to 5, excluding most national holidays. So you call, and so you can either, if you've pre-registered, you just call. You can either register online, or if you haven't used our services before, when you make that first call, we'll register you. It might just take a few extra minutes. And then our support staff will take your name. We'll take down some patient demographics. So we do take the patient's name. This is all confidential. We take the patient's name, their date of birth, the county that they reside in, as well as their insurance. The other question you'll be asked by our support team is whether the patient is working with any mental health professional, either outside of your clinic or whether it's someone embedded in the clinic or at school. And if you don't know, that's fine. And then your call is transferred within a couple minutes to an OPAL consultant who discusses the case with you, offers diagnostic considerations and treatment recommendations. And then after that, after the phone call ends, the consultant writes up a summary, and I'll go into a little bit more detail of that in just a moment. And then that summary is sent to you, ideally within 24 hours, if not immediately after the call. And we send that via fax or email. So the summary that a caller will receive includes a several sentence summary of the case. So for example, you called to discuss your 15-year-old male patient who is struggling with depression and anxiety. And then we might include any medications you told us that they were on, or any psychosocial stressors. And then the next part of our summary includes any diagnostic considerations, if any. Sometimes there aren't, and sometimes there are. And then we'll also provide a summary of any medication options that we discussed. And we'll also include in that any suggested dosing guidelines. And then it's followed by monitoring suggestions. So this includes any side effects to look out for, any vital sign monitoring that we recommend, or labs that we recommend. We also may make some recommendations around the use of rating scales to assess treatment progress or treatment response. Most of our summary notes also include non-medication, non-pharmacologic treatment recommendations. So this might be, for example, recommending a particular evidence-based psychotherapy, recommending particular accommodations for the school, recommending family therapy, and so forth. And then if we have any other comments about the case, we'll include those. And then when we send the email or the fax, we may or may not, depending on the case, attach one of our suggested care guides, and I'll talk about that in just a moment. Our unofficial motto, and we've been saying this for so long that I think it now should be official, but there is really no question too big or too small. I know sometimes, in particular, residents may be a bit hesitant to call us because they may be thinking, oh, I'm not sure that this warrants a call to OPAL. We are happy to talk to anybody who has a question. So a little bit statistics or data. We have had in both programs, both OPAL and OPAL, we've had nearly 3,000 individuals register. Less than half have called for both programs, but we've had over 1,200 different primary care providers call each program. Since we launched, OPAL has answered 8,500 calls. OPAL has been around for a few years less than we have, and they have fielded over 5,500 calls. And our OPAL DBP program, again, which went into effect in July of 2023, has fielded 194 calls. Now, this reminds me that I forgot to mention something, so I'm going to go back here. So DBP, our DBP program works a little bit differently. You call the same number, but because our DBP availability is quite limited, there are far fewer developmental behavioral pediatricians than there are child psychiatrists, and I suspect most of you are aware of that. There are really very few in the state. So we have them on average about 4 hours a week. So you call the number and you make an appointment for a 30-minute slot. Now, if you happen to call when one of our DBPs is on their shift and they don't have a previously scheduled consult, we'll patch you right through, but we do, in general, we require that folks call to schedule an appointment. One of the other pieces, as I mentioned, of demographic info that we collect is there any collaborating mental health professional working with the caller? And in the majority of cases, in about 60%, there is not. So, and then these are some of our call trends. So as you can see, since we began in, this is by fiscal year, and our fiscal year ends June 30th. And so as you can see from the beginning of OPAL K in June of 2014, we started out with just under 500 calls. In 2023, we fielded over 1,200 calls, and there was definitely a big jump from 20 to 21, which I suspect was related to the pandemic. And this is what we want to see. We want to see more people using our services. We also track not only where the patients reside, but also where our callers, what county they're calling from. And this helps us develop and focus our outreach efforts. So Gilliam County is doing a great job calling us based on per capita. Followed by Klamath and Multnomah and then Coos County. And then we have a few folks that aren't utilizing our services quite as much. So we really do try to do outreach like this whenever the opportunity presents itself. So one of the unintended consequences of our, I think, success is that because our call volumes have increased and our staffing at this point at OPAL K has not about 19% of the calls that we get currently, this is from the last quarter of 2023, are delayed. What that means is that about 80% of the time when you call, you will be transferred immediately to a psychiatric consultant. 77%, or actually 78% of the time, that will be by a child psychiatric consultant or a child psychiatrist. But about 3% of the time, if the child psychiatrist or the OPAL K consultant is on another call and you happen to call about a patient between the ages of 15 and 17, we will likely divert that call or send that call to one of our general psychiatrists. And then the 19%, okay, the 19% that there's a delay in transfer, what that means is we take your phone number and we call you back in 5 to 10 minutes when the child psychiatrist is available. And as you can see, this is the call transfer trend. And all of this is information that we send quarterly to the Oregon Health Authority. So this is from a report that I just sent yesterday, showing that as our program has grown and our call volume has increased, we're answering the majority of calls immediately, but an increasing number, there is a delay, and we're working on that. We are requesting additional funding that hopefully will allow us to have our phone line staffed by 2 child psychiatrists each day. And then looking at the ages of youth about whom we're called. The majority are adolescents, not terribly surprising there. We get a fair number of calls for school-age children. You will see, however, also that we have a number of calls for preschool and even infant and toddler age. I joined OPAL K in 2017, and even in the last 6.5 years that I've been at OPAL K, I've seen an increasing number of calls about very, very young children. And so when we started to notice this, we then began to hold discussions about having our developmental behavioral pediatricians also provide some consultation time on OPAL K. And again, and they can answer calls, certainly regarding young children, if there are any developmental concerns, anything that you might consider referring a child to a DBP for, you can call and make an appointment for a consultation. If you're not sure, call our OPAL K line and talk to one of the child psychiatrists. We can walk you through that. And in many cases, we're able to answer questions that come up about this younger age group, the preschool age group, and if we can't, we'll let you know. We'll also consult with our DBP colleagues and provide you with the answer. We also track diagnoses. So we get, as you can see, our top 3 diagnostic or calls regarding diagnosis is anxiety, ADHD, and depression. Now, oftentimes youth have co-occurring disorders, and so they may have all 3 when you call, or 4 or more. So, but this just gives you an idea of the wide range of questions and diagnoses that we receive. When a provider calls, we also collect some data that may be completely unrelated to the call, or it may not be. We always ask in youth 11 and older whether there is or has been any suicidal ideation, non-suicidal self-injury, or a past or present history of suicide attempts. And the idea behind this is we want to collect this data so we have some additional information, but we also want to educate primary care providers to be thinking about suicide and thinking about self-harm. So rather than focusing on the individual numbers, I guess I want to point out is that about a third of the youth of those calls that we've received either have or had, either have a current or past history of suicidal ideation, self-harm, and or suicide attempts. A third had no suicidal ideation to the knowledge of the caller, and just under a third, about 25%, were under the age of 10, so we didn't ask. Another question that we will ask the caller, and again, it may have something to do with the caller's question or not. This is again data that we report back to Oregon Health Authority, is whether there's any history of trauma. And again, the reason that we do this is to help promote trauma assessment, remind primary care providers to consider the presence or impact of trauma that may be an underlying cause for the patient's distress. And what this pie chart shows is that about 40% of patients had some history of trauma, 7% causing symptoms now, 30% not necessarily causing symptoms, another 2% where the primary care suspected trauma but either didn't know or the patient or parent denied. And then we also track outcomes. So again, one of our goals is to keep patients in the medical home. And what this graph indicates is that the majority of the patients continue to be treated for their mental health concern by their primary care provider. Then we also track whether they've got a referral to a new psychiatrist or an existing psychiatrist or psychiatric provider, whether care coordination needs to occur, whether they have been or are being referred to a therapist. We track whether we recommend that the patient be sent to the emergency department. That has happened in a number of cases. I can think of one call that I received from a school-based clinic, and there was concern about mania, and certainly from the description that their provider provided, the youth was in a manic episode and really needed to be assessed in an emergency department. Now, one of the questions or concerns that not infrequently occurs is, I just don't have the time. This is going to take forever. In fact, at a presentation not too long ago, one of the participants said, I really don't have 30 minutes to spend on a phone call. Well, you don't need 30 minutes. The majority of our calls are less than 20 minutes. And the majority of those are about 10 minutes. So anywhere from 10 to 20 minutes. When you call, if you have only 5 minutes, let us know. We will accomplish as much as we can possibly accomplish within 5 minutes. I should add too that in these numbers, it's a little deceptive because when we document the length of call, we also include any time that the consultant spent after they hung up the phone to do any research, to either fully answer the question or find literature to include with the summary. So these length of calls are a little bit inflated. So in my experience, the majority of calls end within 10 to 15 minutes. And I have a few 5-minute calls as well. Okay, so I thought I would give you a few examples about OPAL-K calls. And you know what, I can't say that I'm going to review 4 cases. I can't say that they're typical because there's quite a variety in the calls that we get. But these 4 are taken from actual calls that we received in April. I just went through our database and selected a few, changed some of any identifying characteristics so that I'm not disclosing anything, but I think these are somewhat characteristic of the types of calls we get. Okay, first, and I'm going to read to you the summary that was written. So you called about an 8-year-old male who was formally diagnosed with ADHD about 3 years ago. Later in a neuropsych eval, he was diagnosed with autism spectrum disorder level 1 and generalized anxiety disorder. He's tried clonidine and guanfacine, which interestingly both impacted sleep negatively. Tried on methylphenidate extended release 18 milligrams, and that was found to be ineffective. Most recently, this boy is taking methylphenidate ER 30 milligrams, but it seems to have stopped working. Oh yeah, and he's also displaying some tics. But he's not grown any considerable amount that would make one think that we need to adjust the dose or we need to increase the methylphenidate, but he's sleeping well. And so the question that the caller posed was, what other medication options should be considered in light of these diagnoses? And so what the consultant did, and I didn't look through what the recommendations were, but what they will do is discuss what's the differential, what else might be going on, talking about med compliance and what other supports are in the home or at school, and then come up with an idea of where to go next. Another call is a 16-year-old patient with a working diagnosis of depression who reports that her present dose of duloxetine 30 milligrams is just not working. On this dose, she says she feels more depressed, she isolates more, she doesn't leave home, and if possible, she does all of her school online. And oh yeah, she can't sleep. Now, her therapist suggested that she may have bipolar disorder, but didn't provide you with any data that would substantiate this diagnostic suggestion. However, the family is really interested in trying an antipsychotic. Based on your mental status exam and historical assessment, this patient does appear to have major depressive disorder. You don't see any evidence of bipolar disorder. Complicating matters is that she has a history of adverse reactions to medications. So when you tried to increase the duloxetine, it caused GI side effects. Sertraline also resulted in GI upset, and fluoxetine caused intolerable nausea and vomiting. Bupropion was also tried, but that caused vomiting at 150 milligrams a day. And so the caller's question was, what do I do next? What do you recommend? Another call is a 3-year-old male with in utero methadone exposure, currently residing in family foster care. He's got a lot of difficulty, but sleep is a big issue. He has trouble falling asleep, and he only sleeps for maybe 3 to 4 hours at a time. He's highly impulsive, very unsafe with his hands. He pulls on the dog's tail. He scratches himself when he's upset. He has anger outbursts. He's hyperactive. He has difficulty focusing, and he can be aggressive towards others. Further complicating that is he suffered a concussion several months ago, and that has resulted in worsening behavior. The provider completed a developmental screening with the ASQ and found that it was positive for expressive language difficulties. Now, the challenge in this is that this child has been exposed to multiple languages in the home, and at a time may be using 3 to 4 different languages. So that's been a challenge. And so the question is, well, I'm considering guanfacine to target the sleep difficulty, but I'm also thinking it might work for impulsivity, hyperactivity, and emotional reactivity, but I'm a little worried about prescribing this to a 3-year-old kid. What do you suggest? And a next example is a 14-year-old female with generalized anxiety and some depression. She's been treated with sertraline for some time and initially had a pretty good response at 100 milligrams, but now she reports that her anxiety symptoms have recurred or are persisting. She's been feeling increasingly depressed about this. She's in weekly supportive psychotherapy and has been for over a year. And recently, she has started to just not go to school because of her anxiety, and she experiences GI upset, nausea, particularly in the morning. And so the question is, what do I do about the medication? Do I increase it? Do I switch her? If I switch her to something else, I'm not sure about the best way to make that switch. So those are just 4 examples. And again, I just want to reiterate that our unofficial motto is, there is no question too big or too small. I'm not sure how to make a switch from sertraline to fluoxetine. Great, call us. I've tried my patient on methylphenidate and Adderall, but they have a reaction or it's not working. What do I do? We can help. I want to just, this is some post-service survey feedback. We always ask for feedback. And we sometimes we get negative feedback, not very often. And when we do, we always follow up with the provider. So our project manager places a call, gets additional information, and then we usually have a discussion with the consultant about how that call could have gone better. And then we place another return call to the provider, or we leave a message and just let them know that we've addressed it. So a couple of the positive comments. OPAL and OPAL K are absolutely critical in safeguarding my patients. I have no idea what I'd do without this resource. Thank you so much. This is such a phenomenal service for patients and providers in smaller towns around Oregon. I can't thank you all enough. Really appreciate how helpful this service is. It has been absolutely wonderful for me to have this as a resource in an area with limited resources. The provider I talked with was amazing and extremely helpful and professional. Very helpful and definitely helped me with my patient and their care. And again, this is just a snapshot of the many positive comments we received. We do get a few negative ones, and we do follow up on those because we absolutely want to improve and be the best that we can be. All right, let me tell you, I know I've got a few minutes left. I'm just going to tell you about some other OPAL programs that folks are not aware of. And these are specific actual OPAL K programs. Okay, so foster care program. This is a separate process from OPAL K curbside phone consultation. So annually, DMAP reviews the prescriptions of every youth in Oregon foster care. If the prescription regimen meets one of 6 criteria, medical records are requested and a referral is made to OPAL K for psychiatric consultation. Now, the 6 criteria are as follows. Antipsychotics prescribed for an extended period of time without an approved indication or without metabolic monitoring. 2 or more chronic medications from the same pharmacologic class. 4 or more chronic psychotropic medications, so polypharmacy. Medications at higher doses than FDA recommendations. Medications prescribed off-label, outside FDA-approved use, or without evidence-supported use. And then lastly, psychotropic medications for children younger than age 6, except stimulants in children older than age 3. So what happens is OPAL K reviews the medical record and determines whether a direct conversation with the treating provider is needed. And then when we make that call, it's very collegial. It includes a discussion of the medical indications for the current psychotropic regimen, how well that current regimen is working, and any additional services that either the youth currently has or that we think the youth might benefit from. And then as clinically indicated, the conversation may include brainstorming strategies to revise the medication regimen, as well as identifying additional services that the youth may benefit from. What I have found when I have made these calls is providers are actually really receptive to having a conversation with us. And in some cases, they tell me, oh, I've been wanting to get this kid off risperidone, but the parents don't want to agree to it. And so we talk about how they can, address that. DHS medication authorization. So prior to starting any youth in foster care on a psychotropic medication, consent from DHS must be obtained in written form. And that's obtained through something called the DHS medication authorization form. So this form is completed by the prescribing provider, and it's along with medical records. It is emailed or faxed to the Health and Wellness Services Division of DHS. There, it's reviewed by a team of psychiatric nurses, and if they feel that further review is indicated before DHS can provide consent, then they send it to OPAL K, and then we review it further. And then lastly, we have something called an antipsychotic monitoring program. So this is an annual review of pharmacy records of youth who are covered by Oregon Health Plan. And then youth who are prescribed antipsychotics without an FDA-approved indication or without any metabolic monitoring, we draft a letter, we send it out to the provider, and then we have a phone conversation with them. So all of these programs were implemented to help ensure that foster youth, as well as youth covered under OHP, are only prescribed psychotropic medications when it's in their best interest, and to ensure appropriate prescribing, particularly of antipsychotic medications. All right, and I am going to be finishing up shortly. So future directions, we've had discussions about, we'd love to be able to provide e-consults, telepsychiatry consultations, but we also welcome your ideas. I'll wrap up by saying that OPAL grew out of a desire to fill unmet needs And just our general nature, we've already generated several adaptations. So OPAL K and then OPAL A, now OPAL K DBP, the foster care psychotropic medication program. And so I would ask that all of you think about what are some ways that you can think of that OPAL could evolve to meet your needs and the needs of Oregon clinicians and Oregon patients. All right, so this is how to reach us. This picture is of one of our earliest child psychiatry consultants who's now retired, Lou Sprunger. And then the care guides that we have available on our website, they're in the process of being updated, but for the most part, they're still appropriate. And you can access all of these care guides via this QR code. We also have non-proprietary rating scales on the site, as well as other resources. This is just a snapshot of the resources that we have. And I want to thank you for your attention. Okay, I'm going to stop sharing. And I think we've got a little bit of time for questions or comments.
Thank you so much, Dr. Schmidt. That was super informative. We do have one question right now from Alan Johnson. He did put it in the chat box. He said, is gender orientation a question posed to each caller?
We don't ask about gender orientation. We ask about gender identification. How does the child identify?
Thank you. Are there any other questions for Dr. Schmidt? Oh, I have another one from Alan. He says, I am retired and can only wish that this service was available during my practice years. It seems to be not just a good idea, but an excellent resource. Thank you very much.
Another comment I'll just share is, and I meant to mention this, all but one state in the United States has a psychiatric access line. The one state that does not is Idaho. And then California and Pennsylvania have regional programs. Neither of those programs have rolled out statewide, but they have regional programs. So this is an idea that took hold in Massachusetts and over the years has really spread. And I think it spread because it works. And it's definitely led to improved mental health care for youth.
Any other questions for Dr. Schmidt? Dr. Schmidt, I'll give just 1 second if anyone has questions. One thing I do want to follow up with everybody is that this will be available. It will be posted on our GoTo channel, and you have about 90 days to claim your credit. And Dr. Schmidt, thank you for this, because I did earlier forget to say that this is actually part of your CME, continuing education mandatory requirements. So through this, she's also meeting one of the requirements to renew your license. So Dr. Schmidt, thank you for that. You probably didn't know that we were doing that, but this does count. And so it'll be out there for you to claim. And if you need your license renewed, that's there too. Are there any other questions? Dr. Schmidt, thank you so much for your time.
Thank you.
And I appreciate it a bunch, and everything will be there. And everybody have a happy Thursday.
Thank you. Bye-bye.